Cancer imaging through the looking glass. You might think, well, what's the title about? Through the looking glass was actually the title of the novel by the novel Alice in Wonderland by David Carroll. And the thing is, we're reaching a point in our career where there's so many changes happening in imaging that we're really not quite sure what is going to come out at the other end. And so what I'd like to do is to take you on a journey of where we are today and potentially where we might be heading. So very simply, I just thought that we should reflect that life is a journey and where are we heading. So to do that, I think first we want to examine where we have been so far in terms of the historical development of cancer imaging. And we know that imaging today has resulted from a series of technical innovation. So we know that Röntgen invented the X-ray, or he first discovered X-ray in the late 1890s. And we know that in 1956, the first ultrasound system was invented, a clinical ultrasound system in Edinburgh by Tom Brown and Ian Donnell, and they applied this first to the scanning of the uterus to look at the fetus in utero. In 1972, CT scan was invented as a concept and put to practice by Sir Gordon Hounslow. And this technology has really revolutionized the way we practice imaging. In 1973, MRI was invented, and this was through the work of Peter Mansfield and Peter Lauterbach. And this is now common practice again. And the concept of hybrid imaging was first mooted in 1990. And in the year 2001, David Townsend put in practice the first PET CT scanner. And in 2011, we had the first PET MRI scanner. So we're still currently using all these technology, but these technologies are constantly evolving to be better, and we're actually combining techniques across these modalities to further harness the information that these images are able to provide. So for example, in radiography, and for those of you in a room that practice mammography, we know that 3D mammography or tomosynthesis is a new application of an old technique. We used to do a lot of tomosynthesis sort of imaging when we did IVU studies in the abdomen, but now it is being applied to the breast, and that has been shown to improve disease detection, including the radial scars. It can reduce false positive for cancer, and it can also reduce the number of recall rate at standard mammography. Now, we also know that through studies now, researchers have shown that contrast-enhanced spectral energy mammography can also have a very high diagnostic sensitivity compared with conventional mammogram and contrast-enhanced MRI. So here we have an example of a low-energy image, a high-energy image, low-energy image, high-energy image, and then the recombinant image that shows the enhancing tumor in the upper quadrant of the breast. And this has tremendous implication for developing countries that do not have access to many MRI scanners. And this is a sort of new application of an old technology that we are able to improve the detection of cancer within the breast. Now in ultrasound, we have this technology for quite a while now, and many of you with advanced ultrasound systems in the department will be using a variety of techniques, including contrast-enhanced ultrasound. Photoacoustic imaging is something on the horizon, and what this principle of photoacoustic imaging is that instead of interrogating a tissue with the sound waves, you apply a light wave, which is through a laser, and that causes perturbation of the tissue and causes acoustic reflection to arise from the tissue, and then you're able to measure it using an ultrasound probe. Using this sort of technique, you can look at the differences in optical absorption of light in tissue and give some information about the tissue property. For example, melanin has a very specific spectral absorption, and you might be able to then detect normal nodes versus abnormal nodes. As you can see here, you can see abnormal spectral acoustic information arising from this non-enlarged abnormal node that was only 1 millimeter in size. And we can also harness ultrasound now to provide therapy. So high-intensity focused ultrasound is currently being trialed in both primary prostate cancer as well as bone metastases. And this is one of the recent publications in European Urology in September 2018 this year. You can see that this is a series of 625 patients, and they were able to show that using HIFU technique, you can actually have a very long failure-free survival, metastasis survival, and also cancer-specific survival. On CT, dual energy CT, I think, is available on many of the scanners today. But I don't think many of us in the room are actually using that technology. And in part, that's because of the workflow issues on some of the vendor system that does not allow you to have direct access to the dual energy or the quantitative information immediately. But just by way of one example, we know that because of the KH of iodine is higher at the lower KV, we can if you scan the patient using a dual energy, you can reconstruct images using the lower KEV to enhance the contrast between the abnormal and normal tissue. In this case, a small hypervascular HCC or hepatocellular carcinoma. And if you were able to acquire, for example, iodine maps from the dual energy CT, and you use this as a standard way of scanning, then what you're able to do is to begin to look at treatment response. And here is just a study we showed that responders to a particular drug all showed a decrease in iodine uptake or density after the treatment. In MRI, in body imaging at least, we know that radio acquisition now is widely available on all vendor systems, and it does improve image quality in both children as well as adults that cannot hold their breath. In cancer patients, up to 50% of the patients are unable to hold their breath for 15 to 18 seconds, which degrades the quality of the liver imaging. So here we have a breathal image and a free breathing image, and you will agree that the free breathing image is almost slightly sharper than that acquired during breath hold. And we know that high-speed imaging is also available now on modern MR systems that really allow you to perform imaging very, very rapidly, particularly in the liver for dynamic imaging. And it affords us the ability to acquire this sort of functional maps of high spatial resolution, and the first time be able to combine the high resolution morphology we need for diagnostic interpretation and the additional functional imaging which we can explore for their clinical utility. For whole body MRI, this is a technique that is widening, and you can see that these are the emerging or established application of whole body MRI. So whole body MRI is now used routinely in multiple myeloma and also now being trialed in prostate cancer, breast cancer, as well as malignant melanoma. And last but not least, because I'm not a PET physician, just to really acknowledge how far molecular imaging has come. So for many, many years, only FDG tracer was available as standard in our clinics, but at least in the UK, these tracers are now all available, some only in specialist institutions, clearly, but there is a drive to make some of these more novel tracers available to everyone across the country. And this affords us on the hybrid system to combine the exquisite detail of morphological imaging with the functional molecular information that is more specific towards disease diagnosis. So in terms of the technical innovation that we've witnessed so far, what it means is that we have a suite of tools that allow us to support precision oncology. And increasingly, all these techniques are generating more and more data. And at this meeting, you've heard a lot about data, and we will talk a little bit about what can we actually do with the data and why there has been an explosion of informatics in oncology or cancer imaging. So precision oncology, really, if you don't already know the concept, is about giving the right treatment to the right patient at the right time to maximize treatment benefits, minimize complications, and improve outcome. And this is really performed across the range of treatment, including surgery, drugs, radiotherapy, radiolabeled treatment, and minimally invasive therapy. So in terms of imaging for precision oncology, there are many, many examples. And for today, because of the time limitation, I'm just going to talk about something that's close to my heart, which is whole body imaging. And we know that whole body imaging now affords us the ability to have new imaging biomarkers. It allows us to interrogate tumor heterogeneity, as well as understand tumor evolution and potential treatment resistance. So just by way of example, this is a patient with prostate cancer suspected of metastatic bone disease. This is the baseline bone scan, and this PSA level was 7 nanograms per mil. This was 7 months later, and another imaging study at 11 months. And you can see that it would appear that he has developed a lesion here at 7 months, and then several more lesions at 11 months. But the burden of disease appears to be quite small. Here are the MIP images from the whole body diffusion weighted MRI, and you can clearly see that even at this time point, where the bone scan appeared to only show a single lesion, that the disease was actually quite extensive at that time point. And by 11 months, the body is simply overwhelmed and overridden by metastatic deposits. And therefore, if the treatment decision has not been made to start treatment here, then you might miss the opportunity to actually start treatment early with the hope of actually improving the potential patient survival and outcome. Because we know that disease volume in prostate cancer is an independent prognostic factor for disease survival. So here is just an example of the axial images showing clearly increase in the volume of disease across a single axial section. Now we know that using whole body MRI, we can, in at least this metastatic bone disease, we can derive two potential biomarkers. One is disease volume, and the other is the ADC value associated with those disease volumes. So here we can see that the volume of disease before treatment and after treatment has clearly reduced, and there is a contemporaneous increase in the ADC value. So this sort of biomarker development is important for us to find new ways of describing response in metastatic bone disease. And indeed, we are currently undertaking a multi-center trial in the UK to establish both diffusion volume and global ADC as potential response biomarker in metastatic prostate cancer. We can also use whole body because we are exploring every single part of the body. Whole body MRI can be a tool to understand tumor heterogeneity. So what do we mean by that? We are really looking at different levels of potential heterogeneity. So no tumors within the same body may be the same, and indeed between patients they are not the same. So there is interpatient heterogeneity. There can be intertumor heterogeneity, meaning two tumors within the body are not the same. And then within the tumor, there are also potential biological differences, which we call intra-tumor heterogeneity. And if you sample a particular area within the tumor, for example, in this case, if you look at, say, KRAS mutation status, you can see that not all the cells will be stained with the positive mutation status. So this is the complexity that we're dealing with in cancer biology. But what we're able to do if you're going to perform whole body MRI is that you can track multiple lesions at the same time. So in this case, we can ascribe ADC values to every single lesion across the body. So just by an example of how we can use this to monitor response heterogeneity, so we have a patient with ovarian cancer here, and you can see we have segmented 3 different lesions, one in the pelvis, and one in the liver, and one in the upper abdomen. And you can see the lesions in the upper abdomen start off with quite a high volume, which decreases after treatment, but importantly also shows a rise in the ADC value after treatment. Whereas the more cystic disease in the pelvis, starting off with a high volume and high ADC, actually reduces in ADC, although the volume is also similarly decreased over that period. And what is interesting, I suppose, is after 10 visits, you can see that the ADC values of all lesions approximate each other. We can also use this as a technique to track tumors across multiple time points. So what we've done here is from the whole body MRI of a patient with metastatic colon cancer, there are multiple liver metastases in the liver across multiple time points. And in the chart below, these charts plot on the left the ADC value and the volume that is changing across these time points. And I just want to draw your attention to, firstly, at this particular time point, you can see that the ADC value has reached quite a low value, or continuing to fall compared with previous imaging, although the size of the lesion has remained more or less stable. But then shortly after that, about 3 months after that, that lesion has significantly increased in size. So the ability for you to track tumors using some other information other than size provides you insight into how potentially the tumor biology is evolving across the different lines of treatment. So there's no doubt that if you do whole body imaging technique, be it MRI or even PET imaging, you can begin to look at some of the unmet needs for oncology, including assessment for response or biomarkers for immunotherapy, evaluation of bone disease, characterization of phenotypes, disease profiling, predictive and prognostic biomarkers, as well as to differentiate between post-treatment change and residual disease. And this is our ability to deal with all these problems is going to be really helped by the technologies we have. But at the same time, we are collecting a lot of information upfront that many of the information we're not actually harnessing or making use of. And because of the informatics revolution and the computing power that has occurred in the last 10 years, we're beginning to able to appreciate what the images hold in addition to what we can actually see. So we know that the medical image is digital, and just by a way of comparison is that you can now store the information in a human genome in about approximately 0.75 gigabytes. And it would appear that a series of MRI or CT takes about 1 to 2 gigabytes. So potentially there is even more information in the medical images. Now, clearly, one branch that you've heard at this meeting is that we are able to apply some sort of analysis to all the images they're already acquiring to get additional information from each image voxel that is beyond the ability of our eye to actually appreciate or measure. And of course, with the huge computing power now, we are able to apply artificial intelligence and machine learning to help detect disease, suggest diagnosis, and for decision support. So I'm not going to go through this because you're probably in detail, because you probably heard a lot of this at this meeting. But basically, radiomics is just a matter of applying some sort of mathematical operation to the image so that you're able to generate a series of features. And you heard Professor Fred Pryor talk about feature space the other day. And indeed, you're converting what is visually seen into a series of features that can be mathematically described, and then use that information to correlate with other sort of features that you might obtain from biology or from clinical data. And what is compelling about that, this sort of analysis, that if you are able to subject the images to this sort of analysis, and by applying the right sort of analysis, then you may find that certain features have some sort of prognostic information. So in this very well-cited study by Ertz et al., they were able to show that in lung cancer, depending on the expression of 66 features within the CT of these patients studied, that you can segregate out patients who have better survival compared with those with worse survival. And they were able to do this in 2 cohorts across 2 different institutions. And no doubt, if you read the literature, this body of literature is exploding. So as it stands, there are about 304 articles with the word radiomics in it till October 2018. And indeed, we were talking about one's challenges of oncological imaging and unmet needs. And we know that, for example, the ability to predict or assess response to immunotherapy, as you heard at this meeting, is one of those. And in this paper published in Lancet Oncology in September 2018, it is suggested that a radiomics approach may provide new insights into looking at how patients may be responding or not responding to immunotherapy, looking at tumor infiltration of CD8 cells as the comparator. Now, why we think that this sort of technique is providing new information is that, well, you're beginning to see features that you can't really explain. And so it gives you an opportunity to explore what these differences in expression of phenotype actually means. So here is an example of a study we completed last year in 120 patients on their breast diffusion weighted imaging. And we were looking at only patients with luminal A subtype of molecular expression. And what we found was, interestingly, there were 2 subgroups within this luminal A characterized by these features as shown. And so far, we have not been able to find their relationship with any contemporaneous biological surrogates that are known. So whether these are actually meaningful subgroups or not meaningful subgroups, we don't know. So it provides us as a mechanism to test new biomarkers by looking at the expression of these radiomic features. The problem about radiomics is that, well, there may be lack of consistency in the use of reporting parameters. That's a major problem. There is these parameters, if we speak to people working in this field, are highly sensitive to acquisition factors. And so they can have very poor repeatability and reproducibility. So that will affect to what degree the results from one center can be generalized to other centers. There can be a high degree of inter-reader variability. Clearly, that calls for better standardization. And also with anything where you're looking at large number of potential outcomes, there can be overfitting of data with potential high false discovery rate. Now, I'm just going to talk a little bit about AI and machine learning because it's something that is really quite current, and I wouldn't dwell on it too much because you heard a lot about that, and I'm not an expert, so I'll be first to claim that I'm not an expert. But it would seem that deep learning, which is a subset of machine learning, which is a subset of AI, has really exploded because of the computing power that we now have sitting within our office or sitting within a room in your institution. So very briefly is that we can apply classical machine learning, which really involves an expert, such as a radiologist, saying what the ground truth is. So this is the tumor, this is what it looks like, we describe the shape, so on and so forth. And then we select the features, feed it in a machine and say, well, learn, this is the go truth, this is the truth, and then you then have the classification, and then you apply a new set of data and see how it performs. In deep learning, which is where the interest is at the moment, is that you apply you don't have to necessarily segment out the tumor, but you can apply, feed the image in, and feed these images through a several images filter to find features, aggregate these features, and then put them into some sort of classifier, and then the output. So what this sort of deep learning really needs is huge data set, which most radiological departments really do not have currently. So because of time, I just wanted to say that different departments have actually made use of this technique differently. And I think what is really important is for radiologists to be actually thinking about the problems that you want to solve so that you can meaningfully apply this sort of technique to provide you with specific tools to do the job. So for example, in using random forests, and this is an example that we have used in our institution, you will be able to look at areas of high enhancement fraction versus low enhancement fraction here, and you can see how that actually changes with treatment and give you insight about response heterogeneity. I'm going to just skip these slides about transfer learning. I don't think that's critical. So, it is likely that in radiology, at least, that AI is likely to have a major impact on a range of the entire pipeline of our imaging within the imaging department, from ordering of the patient schedule to actually the generation of the report, because all these can be subject to machine learning. And there's no doubt that this technology or this way of thinking is going to stay. And therefore, in the last 2 minutes or so, I just wanted us to reflect on what potentially the future might hold for us, whether it is going to be one of potential utopia, where we work synergistically with machines, or is it going to be one of dystopia? So there's a view that AI will change radiology, but it will not replace radiologists. But there are others who are not so optimistic. If you think AI will never replace radiologists, you may want to think again. And also personally, I think the way individuals react to these challenges will really much depend on how you think about your own problem. You will probably be thinking about how your work might change, how your income might be affected, will you lose your individuality, will you have more or less responsibility, will you have more time, or what new skills do you need to learn? And the threats are, at the moment, real. Workload, everybody is already working too hard. The speed of innovation is tremendous, and there's already information overload. Wait for another 5 years, it's going to get worse. So AI and machine learning helps us process information, but we have to remember that data is not information, information is not knowledge, knowledge is not wisdom. And at the moment, we have a lot of data, we have some information, it's clear that many of the information that we have do not translate to real knowledge, and there is a clear lack of wisdom. And my fear at the moment is that radiology practice is driven by data and information and not necessarily wisdom, which is about patient care and patient outcome. So I think we should really pace ourselves into the future. We need to be participating, to anticipate change, to create new tools that help us, radiologists, in the workflow, and also engage with scientists and industry, and most importantly, as you heard in the last session, potential patient engagement. Because I do think that for too long, radiologists have become invisible. We're no longer seen as actually contributors to healthcare outcomes. So clinicians deal with the patients, but they don't often even know the difference between a radiologist and a radiographer. And I think we have an opportunity to put right that and rebrand ourselves as an imaging physician. I just want to share in the last closing moment this study that we did, because we really wanted to find out whether the patient actually will appreciate us if we communicated results with them. And this was published in European Radiology this year, and was helped in design by this German psychologist who was intimately involved in the study. And basically, we had two arms, 101 patients in each group. And in one group, we had the opportunity to discuss with the patient before the patient left the department. And in another group, undergoing MRI, they did not discuss the results. And just to summarize the results, you can see that if you do that, patients with consultation, the majority would think that that is a vital part of the MRI examination. Whereas in the other group, if they hadn't been the subject, they say, well, it's fine. And you will also find that, if you communicate the result, they will think you as being more competent as well. The patients will. So I don't think that necessarily it's going to be the information that's going to save the profession, but really how we do rethink our profession as we move forward. I'm very sorry that I've gone a little bit over time, but perhaps what we really want to say and ask ourselves is, life is a journey, where do I want to go? And depending on your decision today is going to affect the collective future of the profession. So with that, I thank you very much for listening.
Mu, thank you very much for a really terrific journey through current status of cancer imaging, with much for all of us to reflect on, looking into